Dr. Gibson, it's really wonderful to have you, and we can't wait for your lecture.
Great. Thank you, Roxana. Now, for my first trick, I will advance my slide. How do I? Oh, this one. Okay. Thank you, Roxana, as always helping me with all the complexities here. I have research grant support from Apple and Johnson & Johnson. I'm going to be talking about a trial that is leveraging digital health. This is all my disclosures. I run a ARO, and there's a lot of sponsors. Well, we have really evolved. I look around the room, I see some of my friends, and we all started back in the day of kilobytes. Then we had some single center studies where we would do things on paper. Then we had multi-center trials, and things got up to, say, gigabytes. But now, in the modern era with cloud computing, we've entered the gigabyte era, terabytes of data per patient. And we're also trying to leverage a new phenomenon, which is patient empowerment. And we're trying to put all that together in new ways that we're executing trials. Let me use the Heartline trial as an example of this. This is going to be a randomized trial. It is a randomized trial of up to 180,000 patients to test whether the Apple Watch with a single built-in lead EKG can detect the new onset of atrial fibrillation in people over 65. That's the primary thing we want to see. But then the other issue is, if we can detect asymptomatic AFib, can we reduce stroke and all-cause death? And here's the punchline. By doing all this virtually, we can do a trial at 1% of the cost that it ordinarily takes. By cutting out all the bricks and mortar, we can reduce the cost significantly, as you're going to see. So again, the primary objective is to detect AFib, but the secondary objective is to see if we can improve hard endpoints like stroke and death. Now, in the old world, people came to the hospital. A nurse and a physician enrolled the patient. The patients were followed up, and their information was collected on an electronic case report form. In a virtual trial, patients are not enrolled in the hospital. You can live anywhere in our country and get enrolled, and you enroll online. And you're not followed up by a doctor or nurse. You are followed up using insurance claims databases to see, did you die? Did you have a stroke? Did you have a bleeding event? The old world was paper. You had to have a local IRB approve the protocol. But in the new world, things are electronic, and you use one IRB, a central IRB. Now, in the old world, we had mega trials up to 10 to 20,000 patients. These were highly select groups of people, which limited the generalizability. But now, in a more modern electronic approach, we'll have tens of thousands of patients, and this will give us a broader range of patients to have a more real-world and broader generalizability of the results. Roxana, all of you all used to sweat, wondering, boy, would we be powered enough to test the primary endpoint? And boy, it would be a stretch to hope that we'd have enough patients to test secondary endpoints. Well, with this approach, we're going to be very, very well powered. We're definitely going to be able to test the primary question. We'll probably have enough patients to test many of the secondary questions. In the old world, if it was statistically significant, it was also probably going to be clinically significant. But as you get more and more patients and have more power, the question becomes, it's maybe statistically significant, but is it going to be really clinically significant? And we'll have to tease that out. And I think we were all happy, at least in the United States, when we can enroll about 0.3 to 0.4 patients per site per month. But you'll hear from Mintu in a moment. They were able to enroll about 50,000 patients per month. We're going slower than that in the Heartline study, largely because of COVID. But the point is, you can enroll many more patients much more rapidly. In the past, you just had to depend upon the patient coming to the hospital, but now we can reach out to the patient through social media, Facebook. We can go on TV and advertise and really reach many more patients with this approach than what we could in the past. And finally, it costs us about $30,000 to $150,000 per patient. In the past, tracking down one patient costs $50,000. 40% of the budget was spent on monitoring. In this approach, we'll spend 1% of the cost. There are no missing patients because no one goes missing in a claims database. And because there's no monitoring to look at the case report forms, that drops the budget 40%. The other thing is patients can access their data. They couldn't do that in the past. They can get on the app, they can access their data. Their family members can access their data as well. I think this will also speed up the review of clinical event committees. We all know that it was really tough to get all those events in the past, but if the events are being recorded in real time based upon a claims database, well, then we can be much more rapid in letting the IRB know what's going on. In terms of compliance, a nurse was checking in, making sure with pill counts, everything was going according to plan. But this will be a much more real-world approach. Now, the exception is if you do have something going on, it's set up so that a family member, for instance, is alerted to the fact that you have an event. And again, many of you served, I see many of you in the audience who have served on our clinical event adjudication committees before, where we look at each case. But here, it's going to be done much more simply using ICD-10 codes, and this will bring more consistency, we hope, to the process. How does a traditional CEC with humans looking at every event, how does that compare to a claims database? And we recently published this working with folks from the Smith Center, looking at the DAP trial. And what you see on the two panels, on the left and the right, on the left you see the CEC results, and on the right you see the claims database results. And what you see is they're very similar. So we do hope that claims data can be used as a surrogate for human adjudication. Who gets paid? In the past, doctors, nurses, the infrastructure got paid to enroll, but it's interesting, we're reimbursing patients now for their time and effort to interact with the app. Not as an inducement, it's been reviewed by a lot of attorneys, but again, to compensate them for their time and effort. And again, by real-time monitoring of claims databases, we hope that we can have a more real-time approach to safety monitoring through the Data Safety Monitoring Board. We have really learned a lot about the importance of missing data in traditional trials, and it is really, really hard to track down patients. But if you're using a claims database, there are very few exceptions where someone would go missing. So I think we are in an era where digital health is really going viral. We're becoming more and more dependent upon it in so many ways. But we have to make sure that technology works for us and that we shouldn't be working for technology. And, having health information also does not equal health care, and we have to make that distinction. But I'm hoping that digital health can be complementary to what we do as doctors and nurses in providing face-to-face hands-on health. But I hope we can put patients back at the center of healthcare by enabling and extending our skills through this. And remember, your iPhone is not your primary care physician. Thank you.
Dr. Gibson, if you would just for a second, because we have 46 seconds, what do you think that the traditional AROs, are we out of business? Are we not going to be at all having any impact anymore?
No, I think we're in business. Our future actually looks bright, but I think it will be different. I think so many of the services have been commoditized, particularly data management, things like that. But our biggest capital isn't financial capital, it's scientific capital, intellectual capital, it's our social capital, and those are never going to go away. And in fact, it actually would be kind of nice to focus on that rather than me worrying about, how are we going to track down every patient and how are we going to make ends meet in a very competitive marketplace. So I think the future's bright.